Thanks for coming. We'll talk about it just a little bit. I have been with Atrium for about 2.5 years. Before that, I was with Intermountain Healthcare in Salt Lake City and led the innovation effort there. And before that, where I started cutting my teeth was at GE, where we shaped what is now known as GE FastWorks. It's the global innovation effort for GE, and where I cut my teeth in the lean startup movement with Alex and Steve and my dear former mentor, Clay Christensen. So those three people had a big influence on how I think about things and what I share. I'm going to try to hop through this so we could just have a dialogue. But this is actually the way I think about healthcare as I compare it to other industries that I've worked in, as empathy is really the heartbeat of it. It really is. When you couple that with curiosity, like a lot of our startups do, then I think you can actually start making a change. But without the two, you can't. I also think we have a problem, though. And it's this. It's probably going to be hard to see that slide, but this is a slide from a good friend of mine, Bob Mesta. And part of what I think the problem is in healthcare is we have this belief, just like they did with the Field of Dreams, if you build it, they will come. And so I have a son who plays minor league ball and another one who plays college baseball. And we love the Field of Dreams, but what most people don't know about this is they went bankrupt twice. So if you build it, they don't necessarily come. And so if you think about this as a startup, if you are driving just ideas and trying to make them stick to the wall, I don't think it's very empathetic, actually. I think it's way too risky, and you're wasting a lot of time and money, not only yours but other people's. And that may be a little bit too direct, but I have met with over 1,000 startups in the last 10 years, and most of them don't start on the right side. And that's with the problem. Like, really understand the problem. And we often said at GE, use the culture to change the culture. Well, in healthcare, we diagnose before we prescribe. In innovation, we often prescribe before we diagnose. That's the cause of so many failures, is we want to rush to something, and we can't. It just doesn't work. But there's a contrast to this from a good buddy of mine. This is him. This is Christopher Charles. I've gotten to know him over the last couple of years. But in 2008, Chris decided he wanted to study water quality in Cambodia. Now, Chris lived in Canada, and so he applied for a grant to move to a really small village about a couple hours out of the capital city to study water quality, and this is Chris sitting in a little flat-bottom boat. He goes over there to study water quality, but he said, Todd, as I was out in the water, I kept noticing when we would come back from fishing, people would just lay around in hammocks all day. Or like Chris, sleep under a mosquito net in a hut 10 feet off the ground because they were so tired. He said, I couldn't believe how tired people were. He said, so it kind of struck a vein of curiosity in me. He said, I just had to know. I said, what did that have to do with water quality? He said, absolutely nothing. But the point is, he wasn't in Canada. He was in Cambodia. He literally moved there to stay there 6 months. So he figured out how to cobble some tools together to test blood. Now imagine doing this in the United States. Look where they are. Dirt floors, open air. It's just unbelievable what they did. The whole story is really quite cool. And he said, I knew going over about 60% of people were projected to be anemic, iron deficient anemic. He said, we did this test and it was 93%, and it was severe iron deficiency anemia. He said, so I started trying to think about what I could do. He said, but Todd, I'm eating dinner and having tea with people all day. And he said, they cook in aluminum pots. And he said, they can't afford to switch to any other pot, which is what? In the 70s, there was research done that said if you eat out of a cast iron skillet, that it actually leaches appropriate iron into your diet. So for those of us who like cast iron cornbread, it's actually really good for you, regardless of the amount of butter. It leaches diet, and the butter just helps pull diet and iron in your diet. But he said, okay, I read that if we put iron somehow into the food, that it would leach in our diet. So he built this. And that is just a little ingot. It's just a little thing of iron, just like that we have in our house. But the issue was he gave it to people, and he said, okay, Dan, I want you to put this into your soups and your teas, and it will leach iron into your diet, and it'll be really good for you. So what do you think they did with it? They didn't do it. They actually used it as a doorstop. And I was trying so hard last night to find this picture of the doorstop. Someone used it to hold up books. They would use it as a coaster. They would not put it into their soups and teas. I go, why not? He said it's good for them. He's a smart guy. He's got his PhD. Well, they didn't do it. And so Chris relates the story to me. He said, Todd, one day I'm sitting waiting for a ferry to go to another island to do blood testing. And he said, I look over and there's an older gentleman carving a fish out of a piece of wood. And he said, it hit me. He said, as I'm sitting there, that a fish is really special in this part of the world. So he went and came back and went to the fishmonger the next day, and he said, okay, what's the most popular fish here? It's a cantrope. But what's interesting about the cantrope is it's also called the lucky fish in that culture. So this is what he did. He took that ingot, worked with a local smelter. I wish I would have brought one this morning, and made that ingot into the shape of a lucky fish. He gave it to people, and what did they do? They put it in their soups and teas. So then as a researcher, he started figuring out, tracking people, and within 90 days, over half of the people were no longer severely iron deficient anemic. Interesting. But what was it that really made this work? He went to Cambodia. He didn't sit in Canada. He went to Cambodia. The moral of the story is, if you're a startup, you've got to go find your customers Cambodia and beg your way to understand it, because a lot of us overlook the fact that culture plays a big part in designing what you do. It plays a huge part, and safety, quality, all these things that are often cultural feelings and practical applications in healthcare are overlooked by early stage companies. There are ways to reinforce this. This is just a cultural thing. They put it in there. And it's quite funny that that worked, but the one on the top right didn't work. So functionally, the thing is exactly the same. Culturally, it's very different. So then they go to India. And what happened when they went to India with the fish? Same damn thing. Oh, sorry. Same thing that happened with the ingot. They wouldn't use it. Why? Because so many people are vegetarians. They wouldn't put it into their soups and their teas. And so they designed the Shakti leaf. And it worked. The idea that I try to get across to everybody in corporations, whether it's startups or whether it's at Atrium or any other place I go, is you've got to go to Cambodia. At Intermountain, they still have that thing. Have you been to Cambodia? Everybody knows that means you got to go to the OR, you got to go to the ICU, you've got to go to the home, you got to go to the SNF. Doesn't matter. So as a startup, do everything you can to film a documentary of the person and their problems, because that's the only way you're going to design something that will delight. Intuit, IKEA, P&G, Pixar, all these companies do an amazing job of it, Amazon included, and that's why they win. It's not because people are any smarter than you are, it's because they do something different. Search. This is what Chris did. By the way, he decided to go for 6 months. He stayed 3 years. This is a slide from my good buddy Alex Osterwalder. And this is something that I really try to help startups remember and hope I can get venture groups to remember. I think Dan does an amazing job of this. Is that until you have enough evidence to write a business plan, you need to be doing business modeling. You need to stay in search mode. This is where Eric came up with the whole idea of a pivot. Your vision stays the same, but your strategy changes. That's really what a pivot is. It's the most abused word in innovation now, but that's the exact definition of it. Stay on the left until you know enough to go on the right. At GE, we used to tease that a business plan was an execution document. You either executed or your job got executed. And the problem is that we were writing these 50-page business plans without enough evidence to execute on, but that's why we wrote 50 pages, is we didn't know enough. So stay on the left and let it be assumption-driven. So here's another one. This often goes away with companies, is you forget to ask the big question. And sometimes the big question is not as big as you think it is. One of the most fundamental questions I think any startup should ask someone is, why do current solutions fail to delight you? Not just why do they fail, but why do they fail to delight you? Then they'll tell you why they fail to delight you, and they say, can I come watch you use it? That's the second big fundamental question. The other one is what do I need to know before I invest more time or money? Like, what do you need to know? And then you start asking people around you, advisors like Dan and Sarah or someone with inside of a health system, ask a lot of questions. And then ask your question, what is my learning plan and where can I learn it? Because often we get into this execution mode and we don't have documented learning plans. And when you don't have a documented learning plan that's assumption-driven, you've got a real big problem. Because then you're spending time and money on assumptions. And by the way, the scientific method happens to be quite inherent in healthcare. Assumption, experiment, test, insight. But I find that so many companies don't do this. At GE, we blew $400 million in one division because we had so many assumptions that turned out to be invalidated, but we were just trying to validate everything we possibly could, and we kind of hosed ourselves. So this is the one thing, if I can tell you as a startup, you've got to get right, is one, I should have made this a build slide. I interviewed 100 people recently, and I asked them their definition of a business model, and not one person had the same definition of another one. That's a problem. So how many of you talk about your business model as a startup? Every damn one of you. If you should, because business models compete, products and services don't. That's just part of the story. And you've got to figure out a business model in the definition of a business model, and that's it, directly from Alex. But if you notice, economic, social, cultural, other context. Clay used to say circumstance is the essential unit of innovation. You got to understand who you're designing for and what the movie of their life is. That's a business model. I did a workshop last week, and I had everybody in the room draw a pain scale. Everybody got it right. It was so close that any of us could have spoken about it. Then I asked them to draw a business model, and nobody could do it. I was like, yeah, but you're all talking about it, but you can't even tell me what it is. And the problem of a lack of a unified language causes companies to fail. This is not because people aren't smart, it's because they're not using tools. 9 building blocks in 3 sections. Desirability, there are far more questions. The most fundamental question you have to ask about desirability is what progress are they trying to make? Where are they trying to make it? Who are they trying to make it with? And then if you have a product, do they want it is an interesting question. The other question is what do they not like about it? You got to find out. Be okay with people telling you what's wrong with your product or with your service. Don't get defensive. Because if you get defensive, you lose. Because people are offering you kind of free advice and opinions. Ask about 100 people, as Steve would say. The desirability part is where all the marketing people get stuck. Oh yeah, man, they're going to want it. Field of dreams problem on the right. On the left-hand side, not trying to be stereotypical, that's where all the engineers get stuck. Can you build it? Because all they often think about is the thing that they're building, not the feasibility of can we do it in a really good way, activities, resources, and partners. It's in a very intentional design beyond the product, way beyond the product. Just remember, Uber, one of the largest transportation companies in the world, doesn't own a car. It's just a fundamental business model redesign. Airbnb, there's so many things you can look at that have figured out the feasibility side. And then all for the investors in the room, they get maniacally focused on the viability of it. And so many early stage companies get pushed too fast to try to make money. That's my one commentary to venture people. I've worked with so many early stage companies where their venture guys are breathing down their throats to get to money, get to money, get to money, get to money. And the health systems are saying, we're not ready to pay you anything. So take a break, slow down, we'll work with you. You have to have all 3 or you do not have a winning business model. You don't. You may have a great product, you don't have a winning business model. And you have to have a winning business model. The reason I bring up Alex's canvases, and this got launched in 2011, is that it gives us a way to talk together, to work together. And all this document is a framework for documenting every assumption that you have. That's what it's for. It's a verb. It's a modeling tool. It's not an execution tool. You stay in search mode with these tools, and it helps everybody talk in the same way. And it just works. It just works. One of my most favorite stories, my entire career. In 2014, my boss calls me one night because my good buddy Fred Holston with Sirius Computing decided to leave and go to Sirius Computing from Intermountain Healthcare. And Mark called me about 9 o'clock at night. He said, hey, Todd, I want you to run the transformation lab. I said, when do you want to know? He said, I'm not asking you. I just want you to run it. It's like, okay. So I decided to run it. And we get in there, and I find out my team is building this watch. I was like, what provoked this? And they said, well, a nurse came to us and said, we need a band or a watch to remind us to wash our hands. Like, it's awesome. So we were fortunate. We had a $250,000 printer. We had a $500,000 5-axis machine. Man, we could build anything you wanted. It was awesome. We could build rib cages. We could build, it just wouldn't matter. We worked with Intel. We worked with an accelerometer company. We literally trained that watch to know if you were moving your hands like you were supposed to for as long as you're supposed to. We knew it. We knew when you walked in the room. That is a version of a smartwatch. And so we sat around one day and I was like, okay, I got to have this. I asked the team, I said, what's the leap of faith assumption about the watch? What has to hold true for this thing to deliver the value that the nurses want, that the administrators want, that you believe? What was the first thing the engineers told me? Got to be waterproof. Did we do that? Yep. What's the next one? Well, that light has to turn green when you've hit the right amount of time because it starts red. So I go, okay, that's cool. Has to tell time. Well, actually not really, because they have a clock on the wall and a clock on the computer, but that's okay. Has to be adjustable, that's okay. I was like, no. We're still missing it. What has to hold true about the watch? You got to wear it. Like, I'm sitting in the room with some of the smartest people I had ever known, and we missed the obvious. And so I started thinking, why did we miss the obvious? I said, no, people have to wear the thing. And I took the sails out of the room, the wind out of the sails. I felt kind of bad. I said, so there's this big misnomer in the world of an MVP, a minimal viable product. People start building stuff before they know enough about what to build. And they always forget the viable. It has to be better than what I have today, or at least as good. So I said, okay, we're going to do something. And this is what I call a minimal learning experiment. And this is where I really want people to start thinking about this more in companies and startups, doesn't matter, big corporations, is what's the minimal learning experiment we can run to test the leap of faith assumption. So I said, all right, we're going to do something. Stop working on the watch. We went to 4 hospitals. We took a piece of paper and a pencil. We walked the halls and said, show us your wrists. And we started noticing that nobody wore watches. And if they did, it's like, hey, would you be willing to take that watch off to put this one on? They're like, no, that's ugly. Or no, this is my husband or wife gave this to me, the whole reason. But then we asked the next question. Where are you not allowed to wear a watch? ICU, the OR, the places where germs are most dangerous. You're not even allowed to wear a watch to remind you to wash your hands. And so they, okay, duh moment. We spent over $200,000 working on that watch. Those are some really nice watches, about $100,000 a piece. They're still in a glass case at Intermountain. But the leap of faith assumption could have been tested with a minimal learning experiment had we used the tools and conducted an assumption burst. This is the one thing that we often miss, is we're not comfortable writing down assumptions. We're so willing to write down all the questions that we have, but not the assumptions that we have. So if there's any practice that you can implement with startups that you're advising, or even yourself, is do an assumption burst. Write down everything you believe will be true in all 9 building blocks of your business model, and design like crazy minimal learning experiments. And here's another one that I often tell a lot of startups these days. Causal versus correlated. This is really important to remember. If I hire your solution, what is it going to cause to move for me that I can know will move and that I care about? Not this correlated thing. That's really hard. Because you can't easily buy things on correlation, because you can't prove the ROI. And for those of you who understand the finances of healthcare right now, $1 is hard to get, because the industry is really kind of upside down and will be for quite some time. And so if you come in promising that your solution will do something, you need to get as close to the lowest p-value as you possibly can, so that if we buy it, we can connect it back to the impact that you promised. And you've got to have line of sight to it. The only way to really get line of sight to that is to be very curious and ask an enormous amount of questions. So my advice to any early stage company, anybody investing in an early stage company, is work as hard as you possibly can to get to causality. It makes it clearer to understand your value proposition and therefore to invest our time and money into working with you. It doesn't have to be crystal clear, but if it's closer for the other 100 startups that will contact us this month, you're going to stand out a little bit better because it is a competition thing of time and money. I'll close with this slide. I love Dan and I love Michigan State. That's not what the slide's about. One of the things that Clay talked about in competing against luck is this notion of a customer benefit metric. What do I want to have positively happen in my life if I hire your product or service? What progress am I trying to make? How am I measuring it? How is it tangible to me in my day-to-day life, and how do you know? Well, a few buddies of mine from Intuit, we're all sitting around when I was saying, we ought to just call that the love metric. If I hire your product, or if you hire my product, what would you love to have happen? And so this is a line of reasoning that you can go to, but the point that I'm making is if you can figure out what someone's love metric is, what they're struggling with and what they would love to have happen, what they would love to not have happen, then that is the essence of the design backbone of your entire solution in your business model, is to be able to design to the love metric. I was talking to a doctor in Intermountain, and I said, does anyone ever come in and tell you they want to lose 10 pounds, 20 pounds? Like, yeah, all the time. I said, well, what do you put in the record? Like, they want to lose 20 pounds. That's not the right thing to put in the record. That's not what's important. It's like, I don't agree with this. So it doesn't matter if you agree with me, it's the person. Let's argue all day long, but what would be good about losing 20 pounds? And it might be the fact that they can ride a big hill on their bike again. It might be the fact that they'll be able to dance with their daughter at a wedding. Like, what is really meaningful to people? Because humans do stuff. That's it. Companies don't buy a thing. Humans buy things. And so if the design of your entire business model and your product is to deliver to the love metric, and you can prove that over and over again in a causal way, you're going to win. You are going to win. And the last thing I will say is I want to talk just about one way of reasoning around questions. Everybody ever heard of the 5 whys? Trash it. It doesn't work. Why? The FBI has done research to know that when they ask the word why, it is accusatory. And it puts people in a defensive mode. I did this yesterday with a young lady who went to Spelman in Atlanta. And I said, why did you go to Spelman? I went there because. It's an excuse. It's a reason. It's a defensive word. Then I said, let me ask it a different way. What caused you to pick Spelman? And she said, it's a place where black magic happens for women. And I said, oh my gosh, what a different answer. So my advice when you are in a conversation with a corporation is ask what? Well, I just hate that. Well, what do you hate about it? Well, it leads to this. Well, what do you hate about that? If you can get to the 5 whats, you can also get to the love metric. It's just a real pragmatic way in flipping the lens to learn what you need to learn. So anyway, that's all the slides. I wanted to leave a few minutes at the end just to have a dialogue. My email is todd.dunn@atriumhealth.org. It's my passion to help shape products and services to help make healthcare better. But that's it. Go find the tools, follow the process. Go to Cambodia. You got to go. Because people don't live in your office. They don't work in your conference room. They work where they are. So context is the essential unit of innovation. That's it. Let's have a dialogue. Thank you. Ask away. Somebody's got to pop the first question. What are some big bets we're making at Atrium? Oh, man. What am I most passionate about? Disrupting the dialysis business model in the country. I think it's jacked up. You can go listen to a Freakonomics podcast on this from 2018. It's done really well. My buddy over at Duke did a lot of the research for it. I think dialysis is a crazy business model, by the way. Dialysis consumes 1% of the federal budget. Think about that. The kidney is actually the most expensive organ in the body. and one of the most detrimental to the whole healthcare system. So I'm relentlessly passionate about that. I'm relentlessly passionate about needle-free blood draw. We can draw blood without a needle by repurposing a catheter in the arm and stop poking people all the time. Oh man, acute kidney injury, all related to the kidney. I really care about that. And then I just fundamentally care about designing business models that people want to engage with. Flip the lens to purposefully designing products and services and business models that not only thrill consumers, but also customers. And in healthcare, of course, the customer is sometimes the payer. The consumer is the patient. Sometimes we're both with these high deductible plans. And how do we, like IKEA and Intuit, P&G and all these companies, how do we flip the lens of understanding to go to Cambodia to put problems in observation versus what we do today? Because I really think we're hyper supply driven in healthcare as an industry, because that's historically how we've been. I think we have to change it. We could go on, but those are just a few that keep me rolling. What I'm saying is I think when we're designing a clinic, let's just talk about a clinic design for a minute. We build a box with computers and rooms and everything else. We forget that people love to go to Disney World and they hate going to a clinic. And so a good friend of mine spent a month of his life living in China, living with people in China. They did this whole thing for months to design Disney China. It paid itself off in 7 years. If you go to France, they lost $3 billion because they didn't do any of that ethnographic work. They didn't go to France. They didn't go to Cambodia. So I'm talking more about how we learn about what people struggle with, what they hope for, and how we remove all of the friction in the experience for the clinicians and everybody else. Yes?
Great presentation, thank you. I love the idea of a love metric. We try to measure social impact or social ROI.
Oh, yes.
Could you give some insights on what you're actually measuring and how you define success there besides the customer love?
Social impact? Mm-hmm. Oh, I think this might be the most difficult thing to really think about. But one of the things we're intentionally pondering how to make a difference in is an upward mobility. We have to do something in Charlotte. For those of you who don't know, Rod Shetty did a report back in 2013 that said Charlotte was 50 out of 50 in upward mobility in the main cities in the country. Well, he refreshed that about a year and a half ago. We're now 97 out of 100. Good Lord. And with all that's going on here, we have to figure it out. So we're very intentionally focused on how do we help with upward mobility. We've got one program, just to give an example, is Restorative Pathways, where incarcerated people have come out and really got their stuff together. How do we create a job path for them to break this kind of cycle of generational no mobility, actually like reverse mobility? So that's one of the things we're relentlessly focused on, is like how many people have we lifted to a better spot in their life based on where they want to be. And you know, this is a hard thing for healthcare systems. The other point though is I think we can't take the burden on us. This has to be a thing of where we create an alliance, a collaborative. We can be a catalyst because we know so much about humanity, but there's so much that we don't know. So I think we have to be careful as a healthcare system not to feel we have to trudge this thing by ourselves. Yeah, great question. Thank you. Yes, sir.
Tim, I wanted to say I'm Ross Steptoe, but thank you so much. This is extremely insightful for a few reasons. You have just validated my 15 years working on a particular problem.
Awesome.
And I think that 15 years has been with clients.
Yeah.
Iterating with them, figuring out what works, being okay with a null hypothesis if something doesn't work.
That's right.
Okay, that's fine. And then how do you adjust according to that? So I just wanted to say thank you again for really just putting down the reality. And I wonder whether or not the whole thought of 17 years to get a medical innovation, how do you bypass that if we really need to spend the time, be with the client to really get iterate. Is there really any way to shorten that time frame?
Yeah. The way I understand the 17 years, and Dr. Brent James and that whole quality movement is the one that did that measure. That's really from taking it kind of from this notion of the bench all the way to the bedside and into clinical practice. Flip the lens. Go from the bedside back to the bench. Start like you are with the problem, because then you're spending less time iterating and in discovery, because you're fishing with the people in Cambodia, bam, and you can get there faster. So I think the reason it's taking so long is because of all the uncertainty up just early. We're not starting with a deep enough diagnosis of what we're really trying to solve for. And when we do that, it harnesses the brilliance of the world. And when we do that, we'll move a little bit faster. That's my opinion of watching this for way too long. Yes, sir. And by the way, you don't have to interview 100 people. I'll tell you why I think it's not 100, but 100 is not, it's better than 5.
So you mentioned that 100 startups will reach out to you for a dialogue a month. What causes you to respond to an email, have that dialogue, and really continue down a path?
Roselli calling me and say, hey, will you talk to these guys? That's one of them. But why? It's the filter. There are filters that I just trust. And I wrote this article for Steve Blank back in 2015 called The 7 Deadly Sins of Healthcare Startups. That might inform you a little bit about how I filter it. It's your tangible understanding of the problem and your curiosity about it. Don't try to sell me the second you hit me.
Sure.
Would you mind giving us 15 minutes just to spend time with us, let us learn from you, and et cetera? It's easier that way. Ask for 15-minute increments. Can we spend an hour together? Can we spend coffee together? Well, I live on the lake. For me to have coffee with you in Charlotte, it's going to take me a couple hours. So usually a filter, if somebody knows me and asks me to do it, it just helps me. I'm not trying to be arrogant with it. It's just, sure. Man, like I could work 20 hours a day keeping up with it. But just Todd Dunn at atriumhealth.org. I mean, literally groups like this is a filter for me. RevTech Labs is a filter. So if you're here, it's a filter. And I'll gladly give you my opinion of what I think is going on.
Great, thanks.
Yes, sir, right here in the blue suit.
Yeah, absolutely. James Lewis, Levinson Innovation Partners. I spent a lot of time with Clay and Patrick back in the day. You captured the essence of that really well.
Yeah.
A question I have is you talked about, we call it demand-driven innovation, where you
100%.
You innovate with the end user, not for the end user.
Yeah.
And part of that is not necessarily filtering the startups, but understanding the problems proactively. My question is, how did you do that at Intermountain at scale, and how are you doing that at Atrium? Because it's not just a startup problem. It's also a big corporation problem where they're not understanding that problem effectively.
Yeah, that's a great question. Yeah, and Clay was amazing, huh? Dear friend. But here's the way I think about it. We have more problems than we can shake a stick at in healthcare. Healthcare prioritizing problems is the most difficult thing in the world, except for with a patient. We have a problem list. So one of the things I'm intentionally working on at Atrium is creating a prioritized problem list based on a strategy that magnifies a struggle to drive us to what to do. 80% of the time, that's where I want to go. The other 20% of the time have to be opportunistic. Because if you just start with the problem list, it suggests that you think you know it all. And the fact that startups will walk in one day and say, hey, we can draw blood without a needle, would you have ever thought about that? No. And so we try to reserve time for the opportunistic stuff, but we have big sets of goals like best place to care and making life better for a physician. And generally what that is, that defined problem puts me on a hunt. And that's when I start reaching out to my network to say, do you have anything that you think would do this? Excellent. It has to be problem list driven. And that's hard, by the way, to get a big, huge behemoth company to do that over and over and over again. To me, innovation is a discipline. You need a system in place. And I think the hardest thing in the world as an innovator is putting an innovation system in place. There are financial systems, clinical systems, marketing systems. Innovation has been about chasing butterflies and shiny objects for way too long. And so I'm trying to shift us, like you mentioned, from the supply side of that equation to the demand side of the equation. But that's it.
Excellent, thanks.
That's it. Yes, ma'am.
As we think about moving healthcare forward,
Yeah.
how do we work to align acute care and all of the many things going on in acute care with root cause analysis and prevention? Like you said, the one system can't do it all, but how do we create those bridges?
Give clinicians time to ask questions.
Oh, that's big, yes.
Because what happens today is a patient comes in, and because the financial structure of healthcare, we're RVU based, right? And so they have to produce to make money to pay back medical debt. I mean, this whole damn thing's really complicated. And so they come in, and I've got 15 to 20 minutes with a patient. Well, so much of it is about just the current condition that you came in for. If you talk to docs, they know enough about the patient, they connect with them. Empathy drives them all. I mean, it's unbelievable what you see from clinicians today. They love people. They just want time with people. So I think the most important thing we need to innovate around is time. That's another one of my passions, is give them back meaningful time. A doc asked me the other day, can you just give me more time to talk about smoking cessation, diet, stress relief, versus you got a hangnail type thing. So to me, it's the only way to get there is to be far more intentional in giving time to the topics that are the root cause of some of these longer term problems like kidney, dialysis, et cetera. Really it is. And I think we have to more methodically talk about it in our culture in the country. We can't lay the blame on hospitals. We just have to talk about it and give time for it, space in our brains. And we got to give the clinical people the space and time to just talk to people and get them on a plan. There's another great program I think we can harness in the country, community health workers. We're doing a lot of intentional work around that. It's how do you harness the natural helpers in an environment to help people who need help where the system isn't having to do it all. It goes back to that ecosystem of time. Great question. Thank you for that.
My question's a little further along the same lines, just about business model and the fee-for-service business model in healthcare.
Yes, sir.
And its impediment, if you will, in my judgment, to time and how we reward and pay. Concepts about how we're going to change without challenging that and how difficult that is.
How difficult that is. I have a viewpoint of this. Watch what the payers are doing. They're doing it on their own. Watch all the acquisitions of Humana, CVS, Aetna. Watch what they're doing. They are buying that. Managed care, value-based stuff. They're buying up all these companies. I've seen Optum's investment portfolio. They're doing the same. But I also have a view of this. This is what a good friend of mine, Mark Johnson and Scott Anthony, wrote about in their book, Dual Transformation. There will never be a switch that's flipped to value in this country. It will never happen. We got to get over the dream. Because the dream puts us in a really odd spot of trying to figure it out, when I think the real fundamental question is how do we run those two models at the same time? At Intermountain, we had about 60% of our people on value, 40% on fee-for-service, and everybody thought we were 100% value. It's like, nope, that's Kaiser. That's not going to happen again. And so I think the methodical thing is to model out these things together and find the Venn diagram of what makes both of them run better. But then you got to intentionally design a model slowly toward value so that over time you ramp up the percentage of it. I actually think that's the most important thing to do, is talk about the business model of it and how do you design mutually beneficial business models under the same roof of a corporation. It's so hard. I mean, it literally is brutally hard. And over time, I think we'll collaborate more with the payers. I'm seeing some things across the country where health systems and payers are moving from combative to collaborative. But without a system like these tools and methods and language, we aren't talking the same language. I think that's the key. That could be a really good coffee discussion right there. It drives me crazy. Yes, sir.
Yes, sir. Thank you so much.
My pleasure.
My question for you is, I'm in learning organization, and so I love the conversation about minimal learning experience. Can you talk a little bit about practical applications of learning for taking that big idea from the supply side to the demand side? Because a lot of times we get a lot of rejection, pushback, don't have time for that in the learning space. How do you actually make those practical learning experiences to help foster those big ideas?
That's a great question. When somebody tells me they don't have time, it just gives me the heebie-jeebies. Like, well, you don't have money either. Like, what do you have more of, time or money? And in healthcare, dang sure isn't money. Just had this. I'll give you a perfect example. I was at this conference last week, and I heard that this team wanted to buy a $30,000 bed. Follow me on this. And that they wanted to remove the front desk in a clinic so people could self-room. I was like, well, what in the world you got to buy a $30,000 bed for? Like, what's your margin in your system? 3%. Okay. So if you spend $50,000 on this minimal viable product, then you've got to generate $1.5 million in revenue to cover up for the cost at a 3% margin. Like, this isn't 50 grand, folks. This is 1.5 million. And so I just started asking questions. What's the fundamental assumption behind this whole thing? So I pushed through assumption burst. And then I asked, what's the fastest, cheapest way we could learn that? The minimal learning experiment. And so we shot the idea of a bed. The team got $500, and interviews are part of it, observations in clinics. And so just ask, do an assumption burst, because a lot of people I'm finding are uncomfortable admitting that they don't know. But if you talk about it in the context of healthcare, it's like, wait a minute, the scientific method is literally the reason we have vaccinations. Go all the way back to Louis Pasteur. He had a theory, and there's nothing more practical than a good theory. It's not theoretical. It's the most practical thing in the world. Germ theory, cell theory, gravitativity, all these things change the world. Jobs to be done theory from Clay change the way we understand people. And then you get them through an assumption burst to admit what they don't know. And then in healthcare, you harness, like, okay, let's walk through the scientific method. Let's design some really cheap experiments. I give you $5 in 5 days. Learn what you can. And you'll be amazed at how smart people are to figure out minimal learning experiments. It just goes back to questions. Stay curious. Ask a lot of questions. It makes people more comfortable. Because I could have told them, that is a stupid idea. 30 grand on a bed? And then you ask the question, if you solve that perfectly, what other problems do you cause? So let's say a patient checks themselves in. The front desk didn't ask all the questions that the doctor doesn't want to ask. So then you just took more time out of the window of the patient and the clinician just to get rid of a front desk. Stupid move, right? And so that's the way I do it. I just keep asking questions. Like Roselli probably collects really fancy cars, and I collect questions. I have a spreadsheet of 340 questions. I'm always adding to it because it's the question that I don't ask that worries me the most. But the practice of an assumption burst. So Buckminster Fuller has this quote: if you want people to think and behave in a new way, don't bother teaching them. Give them a tool that elicits the thinking and the behavior. So it's why I use the canvases. It's why I use test cards. It's why it gives it in a system and it allows us to harness the brilliance versus argue over what's not brilliant. Thanks. How you doing, Dana? Go ahead, buddy.
Hey, Todd. Good to see you. So I'm Kevin Clark, CEO of Point Motion. Something that really stuck with me in your presentation was the topic on the watches that were built, right? And talking about how ultimately, we put all these efforts into innovating things when a conversation, which is free, can really bring us the answers that can not only save us capital, but bring us quicker to our destination.
Oh, yeah.
Something I found in running a patient-centered digital health tool, right, is that fear and pain are one of the biggest contributors to lack of engagement and traction within digital health experiences, patient experiences. And something in that makes, when you talked about how the referral is a big part of how you filter out, products and that you want to start exploring, something that really I was wondering is what is really the most, what would you find more convincing? Hearing from a doctor within your system about a digital health product that is really inspiring to them, or hearing from a patient about a digital health product that they're using that's really inspiring and motivating to them?
Neither. But let me explain why. It's not that I disrespect either one of them. They are part of the decision loop. So in Steve's framework, you've got an economic buyer, decision maker, influencer, user, saboteur. And so I really want to learn from all of them. With a patient, there's often just a behavior assumption, right? Which I think we often forget, like the wearing of the watch or the actual logging into the app. So I would want to know from the patient, what behavior did they have to change because of it? Then you mentioned fear or whatever. I would ask, what's the fear? What's driving it? What are you scared of missing? Because in the progress that people want to make, there are things that they want to avoid and there are things that they want to achieve. I would dive real deep with the doctor, ask, what caused you to like it? And so I would talk to both of them. I would probably weigh the doctor heavier because somebody's got to pay for it. And someone has to use the information. And if the doctor's having to use the information, the last thing we can do is give them more information that's useless, that takes time away, makes them work outside of work. But neither one really. I'm just really curious about the clarity of the problem, not only for the consumer, whether the doctor or the patient, but what is the company problem, which I argue is the business model problem. So I'll think about it. Doesn't mean it's right. And the reason I like a filter is Dan knows what he's doing. Dan knows what I don't know. I know what Dan doesn't know. And that makes a beautiful friendship and partnership. I know the guts of healthcare systems. Lived it. It's why I'm bald. Used to have hair like yours. And but Dan knows how to pick young companies, how to finance them, how to grow them. And so I would also probably call the investors. Like, tell me what caused you to lay money down in that bad boy. Because I have to know they're going to be viable, and I don't want to go through the time of figuring it out. Great question. Thank you. One more, Dan?
That is that time.
We're at time?
Yep. Yeah.
Awesome.
Great.
Thank you.
Yeah.
Oh, thank you.
I'll take over.